Yes, so good evening, everyone. This is Dr. Munjal Pandya. I'm hemato-oncologist and bone marrow transplant fellow, and practicing hemato-oncology for last more than 2 decades and seen quite a good experience clinically, especially hematology. And I'm a coach and mentor on various platforms, nationally, internationally, especially for USMLE and Middle East country. And I'm glad with my team. This is all my team, right? You gradually knows everyone because they're gonna take the classes and all. So without wasting the time, let's start with the class. One more thing before I start this, those who did not subscribe it, today couple of students also share their own experience that YouTube channel video helped them a lot. And there is absolutely no doubt there are hundreds of videos, absolutely high yield even if you see at least one a day. If you cannot finish one a day, one in 2 days, right? So at least in 1 month you can able to see at least good 20, 15 to 20 videos, and that is close to your 500 1000 MCQ, believe me. So just subscribe it and do it, right? So that would be tremendous helpful while you are traveling, going, coming, right, in the tram or car or whatever. It's amazing things to just utilize your time, and it is absolutely the high yield one. So let's start with the first question in front of your screen. So first question is female pregnant, right? So our lecture is infectious disease, right? So let's start with the first question. A female pregnant has HIV positive. What is the most accurate information to tell her about risk of transmission to the baby? This is almost every exam they are asking you. Believe me, every exam they are asking these questions. Yes, so you can answer right openly. Don't worry, this is closed group. So I would be glad to interact with you. So, and if you're shy, you can post your answer in the chat box as well. But you need to answer at least what exactly you do when this question comes in your exam. Each and every question is high yield, believe me. Yes, Anisha. So this is breastfeeding. So why do you think, Dr. Anisha, it's a breastfeeding? Why not A, B, C? What is the percentage of transmission? Do you have any idea, please?
So through cord blood,
From the
Yeah, you go one by one. No problem. Dr. Anisha, please.
yes, sir. Through the placenta and other option like blood cord and contamination, there is very less chance of transmission. But from the breastfeeding, there is more chance to transmit the HIV.
Fair enough. Dr. Savita, being a gynecologist, any comment on this question? Dr. Savita, do you have any idea? I mean, how you manage this and
so the risk of mother to child transmission uh, is around 15 to 45%, sir.
fair enough. So you again agreed with the answer D, right? Fair enough.
Yes, sir.
And can you tell
So
me
it
what?
can be reduced to 1% or so by avoiding certain things. Like one of them is breast feeding, and second is not allowing the patient to have a normal delivery. So go for a electric cesarean.
Wonderful. Do you know what is ARV in pregnant woman, ARV in pregnant woman, and best recommended and contraindicated drugs in the drug from the ARV list? Do you have any
Is
idea? I mean,
antiretroviral therapy.
wonderful. So ARV is basically antiretroviral therapy, that is anti-HIV therapy basically. So do you have any idea which could be the best, which are the recommended, which are the contraindicated drug in the pregnancy? Because these all are questions very frequently asked. So we are trying to solve a lot of question in one question. So no worries. Let's go to the literature. Without literature, it's not helpful. So option is the breastfeeding is the correct answer. Breastfeeding is a well-established high-risk route for of HIV transmission with 15 to 20% additional risk if the mother breastfeed without ART. So if mother is on ART, if she knows, then this is different story. Without ART, could be the high risk. Among the options given, the breastfeeding is the most accurate and most clinically emphasized route because It is directly body fluid exposure, virus in the breast milk. Number one, it is preventable. Avoid breast milking, breastfeeding, or use ART, antiretroviral therapy, which reduces the chances significantly. And modern guidelines strongly warns the HIV positive mother do not breastfeed, making it the most actionable and relevant advice. So this is what the thing is. Let's see, like as usual, why not the other options? That is also equally important for us to know. Why not the other options? Likely transmission through the placenta. HIV can act, right, cross the placenta, but it is not the most likely route. With the ART, the transplacental risk becomes very low, and question asks for the most accurate information, not just the possible route. So most accurate information is the breastfeeding. So through blood cord, right? That is what the second option here. So all options we are trying to exclude in each and every question. So our job is not just to get the answer, but also exclude the other option, right? So blood cord transmission do not occur through the umbilical cord. Transmission happen in utero, transplacental during delivery, exposure to the maternal blood and secretions. Blood cord is not a meaningful or medically recognized transmission route. Contamination too vague and not specific mechanism, not medically accurate to tell a patient's contamination, right? So what's the correct answer in the context of the question? Breastfeeding is the most correct, appropriate, clear, well proven mechanism, strongly emphasized in HIV counseling guideline, provide the most accurate and clinical use information. Let's little deep down into the medicine, right? First line regimen in pregnancy, current standard, right? Dolutegravir, tenofovir, lamivudine. So this is short form, effective, safe, and recommended in all trimester. So whether you know these things or not, you need to remember these three drug. Why? Because it is effective, it is safe, and the beauty is that it is recommended in all trimester. So you don't need to remember first, second, third, what's contraindicated, indicated. So these three are the well proven. And at the same time, what are the not, I mean, truly contra drug, truly contraindicated. So these are the drug and list of the little exhaustive list, but it's important for you to know being a clinician. So these are the drug which are contraindicated in the pregnancy. So you later on little bit study about it, right? So likewise, there are a lot of questions, HIV and breastfeeding, hepatitis B virus and pregnancy, hepatitis C virus and pregnancy, basic drug, right? Preventive drug, curative drug. So you need to little look into this all drugs, right? Basic. So I'm just trying to give you the real idea what, and if you don't know, you need to write down in your notes that this is the homework, right? This is the homework because I'm teaching you the HIV. They may probably ask you hepatitis B virus, right? So, what is the safest drug to control the hepatitis B viral replication in pregnancy? You need to find out. You understand, right? Probably a tenofovir, right? Or entecavir. So, you need to find out the exact reason. So, I'm just giving you the clue. So, that's it. So, answer for the first question is this breastfeeding. This is the most important information. Let's jump to the next question. The most common etiological agent for acute bronchiolitis in infancy is influenza virus, para-influenza virus, rhinovirus, respiratory syncytial virus. I'll give you the 15 seconds for each questions. So you can think it's a one-liner question, so you don't need to struggle to understand the scenario. It's a one-liner. Yes, these all are the frequently asked questions in exam. I select that only. Yes, I got one only answer out of the 8, 10 doctors already joined. So I want everyone, what exactly you do if this same question comes in the exam? Yes, post your answer. Yes, Dr. Khadija, what do you think? What could be the answer for this? Yeah, you can
It's
unmute your. Yes, go ahead. I think
sir, is
something wrong.
respiratory virus the most common cause?
Okay. So not the influenza, not the flu, not the influenza, respiratory syncytial virus. You think it is the most common
Yes, sir.
etiological agent for? Fair enough. So you are absolutely right. Let's dissect it. The most common etiological agent for acute bronchiolitis in infancy probably different from the adult. So we are exactly now targeting the infancy. So respiratory syncytial virus, why RSV, shortly it's called as RSV. RSV is responsible for up to 90% of the bronchiolitis cases in infant. It typically affects infant less than 2 years. Peak incidence occur during winter months as usual. Why not the other reasons? Influenza, para-influenza, and rhino are also in the option. So why not that? So influenza virus causes flu, not the main cause of bronchiolitis. It causes the flu, but not the bronchiolitis. Para-influenza virus cause croup. You know the croup, right? Laryngeotracheobronchitis. That is called croup, right? Laryngeotracheobronchitis. So let's we see sometime in pediatric part mainly, right? So that is done by the para-influenza virus, right? So don't get confused. Para-influenza virus, croup, influenza. It is mainly cause the flu, not the bronchiolitis. Rhinovirus, common cold, right? Mild lower respiratory involvement, but not the main cause. So what's the main cause is a respiratory syncytial virus. Noise, if you are not speaking, you can make your mic unmute. Mute, sorry. So I'll mute it all so you can unmute while you are interacting. Yes, let's jump to the next third question. The most common cause of meningoencephalitis in children. Meningoencephalitis in children is HSV virus, measles, arbovirus, enterovirus. So what could be the answer? Yes, Garvita, you can reply this answer. Last answer is correct. You hit the right answer. So what is the answer for this, Dr. Garvita? What do you think? Don't worry about right or wrong. Just discuss. You never ever forget. Yes, please. Yes, Dr. Alam. Any comment, Dr. Deepika, Dr. Anish, sorry, Dr. Najir, Dr. Savita, what do you think? What could be the answer for this question? Yes, no one. Anyone wants to comment? This is all absolutely high yield questions. I not started the complex question. This is the first prima facie I'm trying to teach you. Second level would be high and third level would be absolutely toxic one. But we need to practice definitely. Yes, doctor. Yes, Khadija, any comment? Fine. So this is what the enterovirus. Yes. Yeah, go ahead.
No, sir, I was wrong.
So that was your answer, Dr. Khadija. Enterovirus. You were thinking of this virus only for the meningoencephalitis in children. So if you're thinking this answer, you're absolutely yes. Enterovirus. Let's see what is enterovirus. So enterovirus is especially Coxsackie virus and ecovirus are the leading cause of viral meningitis and meningoencephalitis in children. It accounts for 50 to 90% of the viral meningitis cases. So this is absolutely done. Why not the other option HSV, that is herpes simplex virus? So HSV, especially HSV1, is the most common cause of sporadic severe encephalitis, but not the most common cause amongst children, right? Measles can cause encephalitis, but it is rare. And arbovirus causes seasonal encephalitis, West Nile fever, but far the less common than enterovirus. So enterovirus top the list of this meningoencephalitis, right, in the children. So that's it. Let's jump to the next questions. So very important and interesting. Here we check all our tuberculosis knowledge. The most appropriate test to assess the prevalence of tuberculosis infection in a community is options are mass miniature radiotherapy, sputum examination, tuberculin test, clinical examination. So what is the question? Try to understand once again. I'll read it for you. The most appropriate assess the prevalence of tuberculosis infection in community is. Now your answer. You can post your answer in the chat box if you shy to these things. Yes, Dr. Khadija. So sorry to ask you several questions. So now you tell me, first of all, how you differentiate latent TB with the active TB. So let's dissect these things, right? Latent TB. Have you heard of the latent TB and active TB? Yes or no? Yes or no?
Yes, sir.
Right. So you start now. I want to know what is the latent TB, definition of latent TB, right? Number two is how you diagnose latent TB, how you treat the latent TB, what is the investigation of the choice for latent TB, and likewise the same questions for the active tuberculosis. So it's a head-to-head comparison between latent TB and active tuberculosis. Starts now.
Mm, okay.
In latent TB, the bacilla is present in the body, but there are no proper clinical symptoms. Sputum examination is negative.
Wonderful, brilliant. What else? You are absolutely going great. You hit the right answer. Perfect. Anything else? That's it. This is what the thing is.
Yes.
Okay. So how you supposed to diagnose latent TB? Say for example, I'm saying, doctor, I'm confused between latent TB and active TB. Can you tell me what are the investigation of choice for latent TB?
IgRA assay.
Right. What is that?
Uh,
Yeah, I'm asking Dr. Khadija, but anybody can comment, right? This is our coaching and this is absolutely a learning platform. You won't get this opportunity to discuss such important topics one to one. Yes.
A
So you think over
positive
it,
tuberculin test, but no symptoms.
positive tuberculin test but no symptoms. Wonderful, brilliant, absolutely perfect. So positive tuberculin test but no symptoms. Absolutely. Wonderful. So let me take you to the journey of latent TB versus active TB. Though we have read hundred and hundreds of time, but we don't know. So today you get the 100% crystal clear clarity between latent TB and active TB. So let's go by the symptoms. What is latent TB? There is no symptom, no symptoms at all. That's it. Right. So I could be myself, Dr. Munjal could have latent TB. Why? Because I don't have any symptoms. My X-ray is normal, my sputum is normal. But if somebody does my tuberculin test, it could be positive, right? So this is latent TB, right? And why latent TB is important, I'll tell you in the next 1 minute. So symptoms is none. Here symptoms are present. What are the symptoms present? Fever, night sweat, evening rise fever, right? Weight loss, blah blah. These are the all classical symptoms. And in advanced stage, hemoptysis, right? And then there is a lymphadenopathy on the chest X-ray, right? So these are the classical features of active TB, which is absent absolutely in the latent TB. Number one, is it contagious? No, it is not contagious, right? It not spread from one person to another person, right? Is it contagious? Yes, active TB is contagious, absolutely contagious, right? X-ray is normal here. X-ray is normal. So on normal X-ray, you can't say anybody, oh, you have no latent TB because in latent TB, X-ray is normal. Here, X-ray is abnormal, right? You may see in the X-ray there is a cavitation in the upper part, right, or hilar lymphadenopathy, right? These are the common presentation of tuberculosis along with the sign symptoms and AFB. Sputum is negative, absolutely. There is no bacteria. Tuberculous bacteria is absent here present. Tuberculin test is positive in both the things. So you cannot differentiate from only tuberculin test that this is active TB or latent TB. How you supposed to differentiate? Once the tuberculin test is positive, right, for anybody as a screening, you need to ask symptoms. Number one, does they have fever, evening rise fever, night sweat, weight loss, right? And chest X-ray. And third thing is in the sputum. So if everything is normal, no symptoms, X-ray is normal, sputum is normal, latent TB. If it is positive, it is active TB. Treatment is 1 to 2 drug, right? Can animal tell me what is the drug of choice? What is the drug of choice for treating the latent tuberculosis? Name of the drug,
INH,
situation of the
INH,
drug,
sir. INH, sir.
INH. Okay, fine. So INH. Second question. How long you supposed to give the INH? Four options. 3 months, 6 months, 12 months, 1.5 year. Quick
9 months,
question.
sir. 9 months, sir.
9 months. Somebody saying 6 months on background. Somebody saying 9 months. Okay, fine. We'll see it. Right. So this is the absolutely head-to-head comparison between the latent TB and active TB. Is everybody clear with this? Yes or no? At least tell me yes or no.
Yes,
Yes.
sir.
Yes, sir.
Wonderful. So I think this is the most simplest form of differentiating latent and active TB. So we don't need to confuse ourselves what is latent and what is active. So I'll jump on that as well. So let's go to the questions again. The most appropriate test to assess the prevalence of tuberculosis infection in community is, the answer is tuberculin. Why tuberculin? Let's dissect. It detects the latent TB infections as well, not only the active disease because it's present in latent as well. Community prevalence studies aim to measure the infection, not the cases. Widely used epidemiological survey to estimate the annual risk of TB. Why not the other option? This miniature radiography used for mass screening of active TB, not the this screening of this latent. What they are asking is, right, the prevalence of tuberculosis, right? Sputum examination, if you detect that sputum, it's a active TB, right? Cannot measure latent infection or prevalence in the community, and clinical examination, low sensitivity, cannot assess the community level infection. So this is the crux and take home message once again. Latent TB key feature: person is infected but not the sick. Patient is infected, not the sick. I myself is infected because I've seen thousands and thousands of patients in last 20 years. So I probably get infected. This tuberculin test could be positive, but I have no symptoms. My chest X-ray is normal. I have no sputum. My sputum AB is normal. So I could be a latent TB. TB bacteria present in the body, but it is inactive. And when they are inactive, they cannot spread. That is why they are not contagious. We have seen it. No symptoms, non-contagious, chest normal, sputum normal, tuberculin test, or IGRA, IGRA. So I think Dr. Khadija is talking about this test, IGRA, right? So go and read it. Go and read it. What is IGRA test, right? So two tests you can see, right? Either you do the Montux or you do the IGRA test, right? So this is homework. What? Go and read it. Do some exercise. Immune system keeps bacteria controlled in the granuloma, right? That's it, right? So this is what the thing is. What is the beauty of this? Why we need to know the latent TB? What is the importance of? You are saying, sir, everything is normal. Then why we are discussing the latent TB? The only reason for knowing and discussing the latent TB is this. What is the risk of latent TB? 5 to 10% progress to active TB, especially in an immunocompromised patient. That's it. This is the beauty. Why we are concerned about the latent TB. 10% means if say for example 10 patient you see a year, out of 10, one patient, right, of latent TB will go into the active TB, especially which category? The immunocompromised. The immunocompromised. Immunocompromised. What do you mean by immunocompromised? Those immunities compromised, like long-term steroid for any reason, long-term steroid, any reason, organ transplantation, chronic uncontrolled diabetes mellitus, all leukemias and lymphomas patient. This all are the group of the people they are immunocompromised, and last but not the least is HIV, immunocompromised, right? Immunity is hampered, T cell is gone. So these are the group of the people. They, right. So if the HIV patient get the latent TB, right? If you do the HIV patients this tuberculin test, and if tuberculin test is positive, what's your action is to treat it, because they will going to go into the active TB, and you don't want them to go into the active TB. How you prevent, how you treat? This is the beauty treatment, right? So somebody told preventive therapy, right? Isoniazid for 6 to 9 months. Correct answer. If you isoniazid is contraindicated by any means, or bad liver, right? Or patient has cirrhosis, where you supposed to not give the INH because it's a hepatotoxic drug. In that case, rifampicin can be offered. That could be for 4 months. And if you want to give both the drugs together, INH plus rifampicin weekly for 12 dose or 12 weeks, right? So that is the thing, right? And likewise the active TB, everything is there. Person is infectious and sick, bacteria are multiplying, chronic cough, fever, weight loss, hemoptysis in advanced case, contagious, especially the pulmonary tuberculosis, abnormal X-ray, cavitation, infiltrates, and sometimes lymphadenopathy is very common in hilar lymphadenopathy. Sputum smear or gene expert or TB culture could be positive, just to diagnose and treatment, right? So four drug AKT, four drug regimen for 6 drugs. So four drug for, right, four drug for 2 months and two drug for 4 months, like that. So 6 months in general, the treatment is important with the key drugs: isoniazid, rifampicin, pyrazinamide, ethambutol. So another homework, there is a lot of question on the side effects. So INH, what is the side effect? One is a hepatotoxicity. So every 2 weekly you need to monitor LFT, liver function test, and peripheral neuropathy. To avoid that, we give the vitamin 1, vitamin 2 supplement with all patients who are on INH, that is B6, called as a pyridoxamine, right? So pyridoxine is a vitamin B6, we'll give it, right? So INH, rifampicin means red, all red, red color urine, red color stool, red color eye, right? tears are also red. So everything is red. This is also hepatotoxicity. Ethambutol, right? Ethambutol is like optic neuritis. Optic neuritis. Etham means optic neuritis, right? And pyrazinamide, again, pyrazinamide is also can cause hepatic toxicity, neuropathy as well. So these are the basic drugs which you need to know the basic information about this drug. They're gonna ask you many a times about the side effects as well. So I'm trying to catch up all the practical aspect what they're gonna ask you in the exam. So let's right. So this is the bottom line. So this is what about the tuberculosis. The answer is a tuberculin test, right? So now you need to know, you get the idea, clarity, what is latent TB, what is active TB, right? How you investigate, how do they present, what are the investigations, and this X-rays and sputum behave in both the ways, and how you supposed to treat them. So that's it. So for little bit more detail, you go open up our website, do the mock test, you get a lot of questions, right? Is that clear to everyone? Yes or no? Is that clear to everyone?
Yes, sir.
Thank you, Deepika, for reply. Wonderful. Let's jump to the next question. 18-year-old male college student is seen in the student health clinic for urinary infection frequency, dysuria, urethral discharge. What, oh, sorry, which of the following is likely to explain his condition? Herpes simplex, Escherichia coli with urinary tract infection, considered to be one of the most commonest organism in urinary tract infection in male female, chlamydia, urethritis, syphilis, HIV infection. So those who are joining me first time or they did not have idea, this is the key to success for any exam. This triad I did not give, it is patented by me. You need to know three things in this triad: diagnosis, investigation, treatment. Here there is no diagnosis. They are directly asking some kind of organism here. Herpes is organism, E. coli organism, chlamydia organism, right? Treponema pallidum, right? Or syphilis or HIV. They, right? So you need to make diagnosis. You need to make some kind of differential diagnosis by reading this MCQ. So what could be the differential diagnosis in this patient? I want to get this. Forget about ABCD now. Yes, Khadija, any comment? Yes, Garvita, would you like to comment on this? Don't shy, you can unmute your mic, you can discuss. Yes, anyone, any volunteer. I need one volunteer for one question, just to have a discussion proper and to understand the thought process, why they are thinking. Yes,
UTI or urethritis.
Chlamydia
Dr.
urethritis, sir.
Yes, Alam. What do you think,
Chlam-
Dr. Alam? Let's discuss. Right. So, what could be your diagnosis, sir, or differential?
Sir, in chlamydial infection, I think because of the pain while urinating and discharge from genital. So these are the symptoms that.
Fair enough. So,
That's
you
why I'm saying.
think that this is the answer, right? Chlamydia, urethritis.
Yes, sir.
Now, let me ask you a couple of more questions. Why you are not thinking it is UTI? Because it is
Fever
young
is
male,
not there,
here
sir.
the urinary frequency, dysuria. Why you are not thinking UTI? I'm just trying to understand.
No
We'll
fever,
dissect
sir.
each and everything.
No fever, no
Wonderful.
cold,
N-
no
No
cold
fever.
chills.
Okay, no fever, no chills, cold, right? Right. So
Uh,
this is one thing. Is there any other reasons why it is not
Sir, there will be no
urethritis?
urethral discharge.
Wonderful,
Mm.
brilliant. So there is no discharge. There is no discharge. It just the urinary increase the frequency, burning in the urine, pus cells in the urine, right? You see, and the E. coli and all, right? But they never ever have urethral discharge. Urethral discharge is something different from the UTI. This is the most demarcating and differentiating point from all the context. So let's just dissect. So absolutely, you both are correct, doctor. The answer is chlamydia urethritis. Let's dissect why this not. Our job is not just to get the answer C. Our job is to why not A, why not B, why not D, why not E. So let's dissect that part as well. The symptoms is urinary frequency, that could be in UTI, dysuria, that could be in UTI, but urethral discharge could not be there. So in 18-year-old sexually active male, this picture mostly strongly suggests urethritis, especially non-gonococcal urethritis. The most common cause of non-gonococcal urethritis in young men is Chlamydia trachomatis, right? Why not other? Herpes simplex causes painful vesicle, right? Have you seen herpes simplex, herpes zoster in the dermatomes on the cervical region, in thoracic and lumbar and all blah blah, right? Again, it's seen more commonly in immunocompromised patients. So I have many patients in my OPD, right? Leukemia, lymphoma patients, they are on multiple chemotherapy, bone marrow transplantation. So they have a lot of herpes simplex and herpes zoster I'm seeing in my day-to-day practice because of immunocompromised patient. They are not mentioning here once again the immunocompromised, right? And they classically present with the severe pain, right? Severe pain, usually severe burning pain in the nerves, right? So neuropathy, what you exactly called as a, and you see the painful, number one. Number two, vesicle or ulcer, not the discharge. Is that clear? Yes or no, Dr. Alam? Right? So this is not the case. E. coli UTI, why it is not the case? More common in women, not in men, but still urethral discharge strongly points to an STI, sexually transmitted infection, not just the simple UTI. Syphilis, primary syphilis, painless canker, no urethral discharge, no urethral discharge. So here no urethral discharge, here no urethral discharge, here no urethral discharge. Rest of the things I explained you. So finally concluding our talk is like of chlamydia urethritis. What is the treatment? Again, you need to know what is the treatment. So anybody knows? If you don't know, I'll give you the treatment. So treatment of choice for chlamydia urethritis is azithromycin, not 500 milligram, 1 gram orally as a single dose. So if you give the 1 gram single dose to the client and partner, you need to treat the partner as well. Don't get confused. It is not just the only treatment to the client or patient. You need to treat the partner if he is sexually active. So azithromycin 1 gram, it's a macrolide group of the drug. Macrolide, it is a drug of choice for the community acquired pneumonia as well. Just second question. So azithromycin 1 gram orally as a single dose, or azithromycin or doxycycline 100 milligram twice daily for 7 days. So here dose and so three different things, right? So here if you use azithromycin, right? Three things: azithromycin 1 gram single dose. Here all three things change. Doxycycline 100 milligram twice a day, 7 days. So you need to know current regimen, preferred regimen by CDC, Community of Disease Control US, and World Health Organization Geneva. Doxycycline 100 milligram twice daily for 7 days. More effective, especially for the rectal chlamydia, lower failure than the azithromycin. So if somebody is asking amongst these two, what could be the best? Doxycycline. Reason, more effective, especially for rectal chlamydia, lower failure rates than azithromycin. Alternative, if poor adherence expected, single dose azithromycin. That's it. So this is what the treatment as well. So right. So our triad, as remember always the triad. If you remember the triad, you never ever you will be a master of the MCQ. Diagnosis we need to know, investigation we need to know, treatment. So whenever from today or tomorrow onwards, when you solve, say for example, 25 MCQ you solve tomorrow, that means you solve 75 MCQ. Why? Because in each MCQ, you need to ask yourself, what is the diagnosis? That is one MCQ in your exam. If they ask you, what is the best initial investigation? Second exam question. What is the treatment of choice for your scenario? Third exam. So 25 question is equal to 75. That's it. So this is how you have to prepare from tomorrow onwards. That is how I am doing for years and years in my practice. That makes me more stronger. So partner management, all sexual partner from the past 60 days, means 2 months, must be treated. Abstain from the sex until 7 days after treatment completion. So somebody has taken 7 days course of doxycycline, abstinent for 7 days. That's it. And you have to treat the partner, right? For past 6 days must be treated. Important. Co-treatment for possible gonorrhea. If somebody has a dual infections, right? Gonorrhea as well. Then right. Then add the ceftriaxone single dose 500 milligram intramuscular. It is a common goes together, right? So that's it. This is chlamydial urethritis. So I think I'm very much clear from my side. Is that any confusion, Dr. Savita? Is all clear to you?
Yes, sir.
Wonderful, brilliant.
Yes.
Let's Wonderful, brilliant. So let's jump to the next question. The patient with mucormycosis should be treated in a tertiary referral center with the subspecialty unit experience in the care of the condition of the underlying case causes, correction of the underlying abnormality and prompt institution of which of the following drug is important, right? So don't get confused. It is simple question. Patient has a mucormycosis, right? Now you want to treat the mucormycosis, right? In a tertiary center, in the hi-fi hospital where everything is available. So what you supposed to use? Either liposomal amphotericin B you gonna use. You want to use fluconazole intravenous. You gonna use voriconazole, ketoconazole, or caspofungin. What is the treatment of choice and why? Let me add one more question to confuse you, F options. Amphotericin B only. Amphotericin B. So there are two options. Amphotericin B liposomal and conventional amphotericin B therapy. Whatever you select, A, B, C, D, E, I want to know each and every options and why. Yes, anyone, any volunteer. Dr. Najir, would you like to comment on this? Yes, anyone, Dr. Garvita, any comment? Yeah, these all are the high yield questions in exam. You need to speak up. Yes. Yes, Khadija.
I think it's liposomal amphotericin B since the other drugs don't have coverage for mucormycosis.
Sir, due to
Wonderful.
low toxicity and there is less like damage to various parts of the systems such as kidneys. So
Wonderful.
I
Brilliant.
think those are
Wonderful. Brilliant. You are absolutely right. You both are right. Right. So liposomal amphotericin B, right, is the biggest advantage of liposomal amphotericin B against amphotericin B is the toxicity profile. As you rightly mentioned, the various organ, especially the kidney, right? So mucormycosis, let's see little discussion about this. So drug of choice for mucormycosis is liposomal amphotericin B. Why the liposomal amphotericin B? Let's dissect that. It is a first line most effective drug against mucorales spices or mucormycosis, preferred over conventional amphotericin B. Why not amphotericin? Due to the less nephrotoxicity, as Dr. Garvita told, and higher tissue penetration. So two advantage, not just the one toxicity, but it's a better tissue penetration, right? So its effect is good, and that is why it is the most effective. Why? Because it's a higher tissue penetration. Is that clear to everyone? Yes or no? Right? And prompt
Yes.
initiation of this drug is critical because mucor is rapid, progressive, and often fatal. Anyone has seen the mucormycosis in their practice? Yes or no? In COVID, there are a lot of mucor,
yes,
lots of mucor. You must have seen it, like nasal, respiratory, and a lot of things, right?
yeah.
Fair enough.
I also.
Wonderful, brilliant, wonderful. So it's a very important, should be keep in mind. Again, it is also seen in immunocompromised patients as well. So recently we had, I mean, one patient just 3 days back of mucor in a maxillary region, right? So we did a lot of scan and biopsies and try to find out the mucor species, right? And if it gets positive, we'll start with the liposomal amphotericin B, not just because of less toxicity, also tissue perfusion is also better. So that's the reason why not fluconazole. That is also in our mind because it has no activity against mucor, no activity. So when there is a no activity, why you want to use this drug, right? When it is ineffective, right? Voriconazole absolutely not used, has no activity against mucor, so it is not used. Ketoconazole ineffective and obsolete for the mucormycosis. Caspofungin, right, have poor to no activity against mucor. So none of them is active against the mucormycosis. So from the list given above, right, only drug of choice for mucor is the amphotericin liposomal. If you have F option amphotericin B, select liposomal amphotericin B. It's the technique of the delivery which reduces the toxicity of the drug to the nephrons or the kidney, and that is why liposomal amphotericin B is the drug of choice, right? That's it. So that is clear from my side. Let's jump to the next question. Febrile neutropenia is the commonest complication of which of the following condition? Right? Chemotherapy, acute myeloid leukemia, non-Hodgkin's lymphoma, HIV, diabetes. What is febrile neutropenia? How you define and how you categorize and how you treat as well. So that is also one question because febrile neutropenia. So you need to know no, what is febrile neutropenia. Second question is what is the commonest complication of which of the following condition is febrile neutropenia. Third is how you categorize the febrile neutropenia. Fourth is how you define the febrile neutropenia, and last but not the least, how you treat the febrile neutropenia. These all are question in the exam. Yes, anyone volunteer.
So febrile means patient will have fever. Neutropenia itself means that there will be normal neutrophil count basically. So,
Wonderful. So normal or low, Dr. Garvita?
okay, sir.
Right. So let me dissect you. It's a very simple, right? Febrile means fever, and neutropenia means neutropenia. Let me give you more clarity. So in CBC you have hemoglobin, right? You will enjoy in my hematology lecture white cell and platelet count. So we are talking about neutrophil. Neutrophil is part of the WBC. So WBC or total WBC or TC we call that in India we call shortly TC, total count. That is total WBC count. And DC means differential count. What are the differential count? Five differential count. Granulocyte means those who are with the fill, PHIL, and site is agranulocyte. This is physiology as well. You will learn physiology with me. Neutrophil, eosinophil, basophil. So phil is behind everything. Neutrophil, basophil, eosinophil. So what is phil? This is WBC, right? This is neutrophil I'm drawing. Three-lobe neutrophil I'm drawing, right? Right. So when there is a granule in the cytoplasm, it is called as a granulocytosis. Granulocytosis. When you don't have granules in the cytoplasm, right? It is agranulocytosis. This is lymphocyte. This is lymphocyte. This is lymphocyte. There is no granule in the cytoplasm. So there are two cells which has no granule in the cytoplasm, right? So it is started with site, lymphocyte, monocyte. So these sites are all agranulocyte. Field, there are three field: neutrophil, eosinophil, basophil, lymphocyte, monocyte. So no granules in the cytoplasm. Agranulocytosis, granulocytosis. So this is basic. Now jump. Now jump. If you have a neutropenia, so neutrophil is supposed to be 60 to 70% normal among slits. So say for example, this patient has WBC count of 8,000. Out of this, 70% up to 70% is neutrophil, right? And second most common is the lymphocyte. 70%, this is 20 to 30%. This is basophil is 1% or less than 1%, eosinophil is 2% to 5%, and monocyte is 1%. So altogether they are cumulatively 100%. So neutrophil and lymphocyte covers almost 98% of the cell. 70% lymphocyte is 25 to 30%, and rest 1 to 2% is all three different cells. So now let's see neutrophil. Neutrophil, if neutrophil is increased, what we call as a neutrophilia. Neutrophilia. Am I right or wrong? Yes or no? If neutrophil is decreased, it is called as a neutropenia. 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 So what we are talking about here is a neutropenia. Now you have more clarity in your mind, right? So whenever less than 60% of the neutrophil, you have neutropenia, and you have more than 80-90%. Say you have bad viral infection, patient has a septicemia, they have 90% of the neutrophil, right? And that shows the severe septicemia where you see the picture, right? So you have a toxic granules in the peripheral smear and neutrophilia, right? Neutrophilia. Is that clear? Yes or no? At least tell me yes or no. At least tell me yes or no.
Yes, sir.
Yes, sir.
Yes, sir.
So far this all clear. Basics is clear now. Basics is clear. So you have fever, you should have a neutropenia, right? So let's count the absolute neutrophil count. Absolute neutrophil count. Another term, new term comes in the picture now. So total count is 8,000, say for example, and neutrophil is 50%. So how you calculate the absolute neutrophil count? So total count multiplied by neutrophil divided by 100. So total count or total WBC count is 8,000 multiplied by 50% of neutrophil divided by 100. 4,000 is absolute neutrophil count. Without knowing this, you cannot understand the category or severity of neutropenia. Is that clear to everyone? Yes or no? Yes or no?
Yes, sir.
Wonderful, right? Same absolute neutrophilia, absolute eosinophil count, same logic applied. Total count, whatever they are asking here, eosinophil, absolute lymphocyte count. So total count, lymphocyte count 100. Likewise, is that clear to everyone? Yes or no? Right? So this is what the thing is. So this is
Yes, sir.
what the classification is. So what is your and my absolute neutrophil count? My and your neutrophil count, right? So I have say for example 5,000 uh, the total count myself and neutrophil is 60%, say for example. So it is 3,000, just for your knowledge. So anything more than 1,500, absolute neutrophil count is normal. Somebody has a 1,500 to 1,000 is grade 1 neutropenia because neutrophils are low. Na? Here what we are measuring is a neutrophil count, absolute neutrophil count. So one category is normal. Anything more than 1,500 is normal. Grade 1, 1,500 to 1,000. Grade 2 neutropenia is now 1,000 to 500. Grade 3 is 500 to 200 and grade 4 is less than 200. It is absolutely atom bomb. Febrile neutropenia is a medical oncological emergency like acute myocardial infarction. So you cannot ignore the way MI patient will die in emergency in front of you with VTVF. They are dying in 5, 10, 15 minutes. They are dying in few hours in front of you. Neutropenia in absence of neutropenia infection cannot be controlled only just with the antibiotic. So you need to improve the neutrophil count, right? How to improve, we'll discuss, right, in a hematology lecture, but I'm just trying to give you. So here we have seen, right, of what fever, definition of fever is more than 38-degree fever and neutropenia. This is a category of neutropenia. So anything less than 1,500 is neutropenia. In short, that's it. Anything less than 1,500 is neutropenia. And again, we are sub-classifying, right? Right? What is a mild, moderate, severe, super severe, or grade 1, 2, 3? So we categorize it, right? We defined it. What is the importance of febrile neutropenia? Why I'm taking bit long? It is life threatening emergency, day to day job in my this area, because and amongst this list the most commonest cause, yes Garvita, what do you think, what could be the most commonest, right? What is the reason, the most common, what they are asking is the most commonest complication of which of the following condition? Is it AML or acute myeloid leukemia, non-Hodgkin's, chemo, HIV, or diabetes? What do you think? What do you think? Anyone?
Chemotherapy.
Chemotherapy.
Chemotherapy. Wonderful, brilliant. Right, so chemotherapy. So febrile neutropenia is a medical emergency. Let's go to the answer. So it's a febrile neutropenia is medical emergency, most commonly seen in cancer receiving the chemotherapy. So there are two words: fever means febrile, neutropenia means low neutrophil count. I told you whole the story. So temperature, right, of 38-degree more than 1 hour or 38.3 is fever. So what is the classification of fever in febrile neutropenia? Is 38-degree more than 1 hour is fever. And what is the classification of neutropenia? More than 1,500 is normal, as I told you, right? Neutropenia mild, moderate, severe, and by me less than 200 is super severe. So febrile neutropenia is usually defined as a ANC less than 500, right? Here 500 plus fever. So these are the people who are at highest risk of getting infection. It's a medical emergency. Why it is an emergency? Neutrophils are essential for fighting two things. Don't just think of bacteria, it is also fungi. So bacteria and fungi, not the virus, not the virus. So neutrophil is very important immune system, right? And lymphocyte mainly for virus, lymphocyte. HIV is virus affecting T lymphocyte, not the neutrophil, T lymphocyte. Just for the basic knowledge. So neutrophil or neutrophils is mainly essential. Absolutely, it's a policeman of body whatever the bacteria and fungi entering to the body, who fights the neutrophil. When you have less neutrophil, less than 500, the body cannot mount the immune response, and this is fatal. Even minor infection, see the word minor infection can progress to sepsis and death. So in my setup, I am seeing everyday patients are dying from febrile neutropenia in spite of the best antibiotic we use. High antibiotic, broad spectrum, meropenem, imipenem, estronium, TG-cycline, targocid, vancomycin. There are long list of antibiotics what we use in our day-to-day practice, but unfortunately still people are dying because of poor neutrophil, right? Poor neutrophil. So we have to be very cautious giving the chemotherapy, and you must give one injection as a prophylaxis. Can anyone tell me what is the name of the injection which increases the neutrophil count? So if you are patient having with a 500 ANC absolute neutrophil count and come with a fever of 38 degree for more than 6 hours, it is classified as a febrile neutropenia. You want to increase the neutrophil count 500 to 1000. What is the name of the injection? It is called as a filgrastim. It is given subcutaneously 5 milligram per kilogram per day. Subcutaneously you can give, right? So in adult, usually 300 milligram ready to use injection is available. So 300 microgram you give subcutaneously OD till the neutrophil counts improve. This is what we do in our daily practice. Every morning we are going into the round and write down a lot of filgrastim. So you need to know what is filgrastim, right? And last but not the least, right? So why this is emergency, we understood, because neutrophil count is very low. Most common cause is chemotherapy, obviously. Why? It suppresses the bone marrow, and it just not suppresses the neutrophil count, it suppresses the hemoglobin. It also suppresses the platelet as well. So you many a times on chemotherapy, one of the most common side effect of chemotherapy is pancytopenia or bone marrow suppression. So I have to explain to the patient, I'm giving you the chemotherapy for the breast cancer. Doxorubicin cyclophosphamide is a treatment of choice, right? You need to monitor the CBC every weekly, and I'm giving you 2 or 3 injection, right? At the time of discharge, you should administer subcutaneously after going home to avoid or prevent febrile neutropenia. That's it. So this prophylactic can be given, therapeutic also can be given, right? So I need to monitor the CBC basically, right? So that's it. And what are the commonest organisms? Somebody has some question in mind, sir. What are the organism? Which infection? You told infection, but what organisms are common? So let me tell you, gram positive, if you get an infection, so somebody has a febrile neutropenia, commonest gram positive is Staphylococcus and Streptococcus. Commonest gram negative is Pseudomonas. It is most threatened, most feared anti-Pseudomonal, right? So we need to give anti-Pseudomonal drug. Again, Pseudomonas, anti-Pseudomonal. Have you heard of it? Yes or no? Have you heard of anti-Pseudomonal drug? Can anyone tell me at least three name of anti-Pseudomonal drug? Three name of anti-Pseudomonal drug which you are using in your practice? Anyone?
Piptas,
Three and yes, write down. I'm writing down, Dr. Khadija. Tell me.
piperazine, tazobactam.
Brilliant. Piperacillin plus tazobactam. It is one drug which is anti-pseudomonal. It acts against the anti-pseudomonas, or it acts against the pseudomonas. That is why the anti-pseudomonal. Yes. What else? So another drug is cefepime. It's a fourth generation cephalosporin. And imipenem and meropenem. So these are the common three drugs. You open up the book of pseudomonal. These are the three drugs what we are using in our day-to-day practice for anti-pseudomonal, because febrile neutropenia is everyday job, right? We have every day at least 1 to 3 patient who is febrile neutropenia. So right, so we define it, we categorize it, we do the blood culture and find out whatever the organism, we start the empiric antibiotic, we do the chest x-ray for pneumonia, and we give the filgrastim, supportive care, and antibiotic. That's it. So this is what we do in our practice as per the standard of care, right? So this is what the thing is about the febrile neutropenia. So that's it. I'm not going much in detail of this. So this is the things, right? So AML, non-Hodgkin's,
Sir,
HIV, diabetes is not commonest cause. The commonest cause is the chemotherapy, which induce the everybody can cause it, but AML. So if I see 100 patient, 95% patient has a neutropenia or febrile neutropenia because of chemotherapy, not just the AML. AML is like subtype, right? So in AML you give chemo, in NHL you give chemotherapy, anti-HIV you give diabetes, right? But the what they are asking here is what is the most commonest cause, right? Febrile neutropenia is commonest complication of which of the, so commonest complication is chemotherapy. Chemotherapy could be for anything, any reason in the body, right? Whatever the condition you can think of, or whatever the condition, whatever the cancer you can think of from head to toe, everywhere we are giving chemotherapy. Leukemia, lymphoma, myeloma, right? Breast cancer, lung cancer, colon cancer, renal cancer, right? Head and neck cancer, right? Respiratory cancer, prostate cancer, ovarian cancer, tubo-ovarian, cervical cancer, sarcoma, lymphoma, whatever you know the name, we give chemotherapy everywhere. And that is why it is the most commonest complication of febrile neutropenia. Yes, I think somebody was asking me the question. Sorry, I missed it.
Yeah, sir, so what can you give to cover fungi in febrile neutropenia?
Febrile neutropenia, there is a yes. So this is what we talked about. So in febrile neutropenia, the protocol international, I'm telling you. So when patient comes to me with the fever of 103 or sometime 101 in our Fahrenheit, if I can talk about. So we give patient first we do the diagnostic workup, blood, urine, chest X-ray, blood culture, CRP or procalcitonin, right? This is basic. We do it. Along with that, we start the treatment. IV fluid is one of the most important treatment. We give the empirical anti-pseudomonal, as I told you. So we'll start the piperacillin plus tazobactam, right? For right on piperacillin tazobactam, if patient does not subside the fever for 3 days, we add usually meropenem to this agent drug. And even fever persists for more than 4 days, as per the guideline, we add the fungal prophylaxis, not from day one. And fungal prophylaxis initially is fluconazole. We add, right? And if fluconazole does not improve, we do some more fungal detailed test of fungal infections, right? And we probably add the voriconazole. We also think of amphotericin B for the amphotericin B, right? As we discussed earlier, or liposomal amphotericin B, right? That is for aspergillosis, right? This is what the threat. And there are also any advances, caspofungin, anidulafungin, blah blah. So this is as per the protocol we add. So answering your question specifically, from fourth day onward, if the fever does not subside, we start the fluconazole empiric, even though it is not documented, no culture positive, no X-ray CT positive, but still we add as per the protocol because these patients are immunocompromised. Are you getting your answer or not?
Yes, sir, thank you.
You got the answer or not?
Yes, sir.
Wonderful,
Thank you,
brilliant.
sir.
Let's move to the next questions. Though every exam, this question is confirmed. This question is confirmed in every exam. Pregnant woman with UTI, which is the best antibiotic, or is to be the safest if there is no allergy. Patient has not allergic to any treatment, any drug, any penicillin, no allergic. Pregnant woman, urinary tract infection, you want to start antibiotic, right? And he has no any allergy. What you supposed to do? Nitrofurantoin, ampicillin, sulfomethoxazole, and trimethoprim, and short form is Bactrim. If you have heard of Bactrim or Septran, right? It is a brand name. So it is a combination of sulfomethoxazole and trimethoprim, tetracycline aminoglycoside. Will not ask to the Dr. Savita because she is gynecologist. She knows. Sorry, madam. Yes, non-gynecologist can answer. Yes, Garvita, what's your comment in this question?
Sir, nitrofurantoin.
Wonderful. You are very brilliant lady. Super. So this is nitrofurantoin, unbiased. Madam Savita, you can comment. Huh? You are like more expert in gynec than me, obviously. Right? This is all my research before presenting my presentation. For a pregnant woman with UTI and no allergy, the best antibiotic of choice is nitrofurantoin. Why nitrofurantoin? That is more important. So safe in pregnancy. Number one, safe in pregnancy. Excellent activity against E. coli. Excellent, not good, excellent activity against E. coli. And E. coli is the number one culprit in UTI pathogens, right? High urinary concentration of nitrofurantoin, and that is why it is very effective as well. So it is safe, it is effective, and it is recommended by many international and this platform, ACOG and WHO. They recommended this for pregnancy associated UTI. Madam Savita, madam, any comment on this? I think how you treat in your practice. Yes, madam. Are you there? Are you there in the class?
Yes, sir. Yes, sir.
Wonderful. So this
Uh,
is the
uh,
same way you
uh,
treat or something else or algorithm for
no, sir.
this?
No, sir. We give nitrofurantoin only.
Wonderful, brilliant, wonderful. So this is unbiased, right? So madam told it's all done, right? She is authority in GYNEC. So this is what the UTI nitrofurantoin. Our job is why not ampicillin? Not preferred due to high E. coli resistance. Ampicillin is now high E. coli resistance, so not a drug of choice. Sulfamethoxazole, trimethoprim, avoid in first trimester, neural tube defect, bad side effect. Avoid in third trimester, cornic teres, bad side effect, right? So it is not a good drug. Tetracycline contraindicated because it stains the fetal bones and teeth, not good drug. Aminoglycoside, fetal ototoxicity and
Ototoxicity.
nephrotoxicity. So we don't need any toxicity to mother or baby, especially they are pregnant, right? So concluding our talk, right? This is nitrofurantoin. What else you can use? Additional safe option. Is there any additional safe options apart from the nitrofurantoin? Answer is yes. Cephalexin is another safe option. Amoxicillin clavulanic, famously known as augmentin, right? And phosphomycin single dose is also used. Is that okay, madam Savita?
Yes, sir. The second antibiotic generally which we use is amoxicillin clavoid.
Wonderful, brilliant. So
Mm.
amoxicillin clavulant, it is a second option when nitrofurantoin not
Mm.
available or some issues or whatever, not in options.
Yeah.
It is mox clavulinate, right? Wonderful,
Yes.
brilliant. So we have additional advantage of madam being in the class. Wonderful. If somebody asks me the weird question, you are my backup. Drug of choice for chronic hepatitis B. Drug of choice. Entecavir, alpha interferon, pegylated interferon, lamivudine.
Entecavir.
Entecavir, wonderful. I have more than thousand, hundred and hundreds of questions for infectious disease, right? So we'll discuss everything. I love it. The drug of choice is for chronic hepatitis B, first line therapy, entecavir. Why entecavir? Potential antiviral activity, very low resistant rate, well tolerated, recommended by first line by various liver bodies and WHO. And along with tenofovir, it is considered the best long-term therapy. The best long-term therapy. Tenofovir is not in the option, so entecavir is the correct answer. So what if it is a tenofovir is the option, right? If tenofovir is the option, then we probably use it. Just 1 second. Yeah, so this is what the thing is. So this is the drug of choice. So just need to remember, right? What is the drug of choice for? You need to remember for each and every drug of choice for tuberculosis, drug of choice for gonococcal urethritis, drug of choice for syphilis, drug of choice for the primary syphilis, drug of choice for hepatitis B, for hepatitis C, hepatitis A. These all are the one-liner, but you need to dive deep into it. I'm just trying to get you through the important high yield frequently asked questions. Let me ask you one more questions. 32-year-old sportsman who recently attended a wild game feed banquet consumed summer sausage made from bear meat. He complains of abdominal discomfort, diarrhea, and muscle tenderness. The most likely diagnosis is trichinosis, salmonellosis, giardiasis, Escherichia lumbricoides, shigellosis. I want to know each and every ABCD organism presentation treatment, not just the one. Yes, please.
Trichinosis.
Yes. Anyone volunteer? Last question for today. No option, no answer.
So trichinosis.
Okay, so what is that? Trichinosis, what is that? Bacterial, fungal,
So it's
viral,
a parasitic kind of infection which is due to roundworms.
roundworms. Okay, fine, fair enough. So what exactly this trichinosis will do in the body? So somebody has an infestation with the trichinosis. How patient presents to you in your OPD? What is organism? This is a disease name or it's organism? Trichinosis is a disease name or organism?
Disease.
Is it
This is caused by which parasite?
So roundworm parasite.
What is the treatment?
Trachinella spiralis?
Sorry?
Trachinella spiralis
Okay. What is the treatment? If somebody get this, what's the treatment?
is
How you supposed to?
anti-helminth,
Oh,
mebendazole and mebendazole.
albendazole, right? So what's the dose you
Yes,
give to the patient?
same it is.
Same means
1
please tell
BID
me.
for 3 days.
Okay, fine, fair enough. No worries. So you this is homework. Sorry to give you a lot of homework today because my class is full of homework. So you need to know all five conditions. Go and read it little bit. Four things you will need to know. What causes this all five organism? What is the sign symptoms? How do they present? What is the or exact organism that cause this mentions disease? And what is the treatment? That's it. If you do this, then 20-30 MCQs is done. Let's dissect the question. So this is what the answer is. The answer is, as Dr. rightly told by Dr. Garvita, it is a wonderful answer. So at bare meat, abdominal pain, diarrhea, muscle tender, it is classical triad for trichinosis. Why this? It is caused by Trichinella spiralis. Trichinella spiralis. The name of the agent is Trichinella spiralis, transmitted through undercooked, not well cooked, undercooked, not cooked well, pork, wild boar or bear meat. So bear meat, it is there in the options or in the scenario. It is important. So early phase abdominal pain, diarrhea, later phase muscle pain and tenderness. It is also there. Fever, periorbital edema, and or almost all parasite can cause eosinophilia. For your knowledge, bear meat is the strongest risk factor, right, amongst all the things. So this is what the important high yield points. Why not other? Salmonellosis causes diarrhea and poultry or eggs. No muscle tenderness in salmonellosis. Why not? Giardiasis causes chronic greasy stool. Important. Chronic greasy stool. So stool is like a very sticky grease like. No muscle pain. Ascariasis, usually lung or GI symptoms not linked to the wild game meat. Shigellosis cause dysentery, no muscle involvement. So, concluding the talk, it is trichinosis. Antiparasite anthelmintic medication is a first line treatment of choice for trichinosis. If the trichinella parasite is discovered early in the intestinal phase, albendazole or mebendazole can be effectively help in eliminating the intestinal worms and larvae as well. So thank you very much all from my side about this infectious things. We'll continue lots of questions on infectious in next coming up couple of the lectures. So before I end up my session, I always take a quick feedback on the class. How did you enjoy it? What was the learning? Or how you get more clarity? Yes, Dr. Savita, I think you joined first time. So how was your experience of this class today? Yes, Dr. Savita, any comment?
Yes, sir. I'm here. Very, very informative, and you're trying to help us to understand the pattern which we should go through, like diagnosis and treatment for every question.
Wonderful, brilliant.
That helps a lot.
Wonderful. Thank you very much. Probably this is your first lecture, so you'll enjoy more in the
Yeah,
next coming up many interactive sessions. It's all
yeah.
concept based. Rather than mug up, just try to build the concept. Whatever they ask, you can easily answer there. I have no doubt.
Yes, sir.
Dr. Alam.
Unfortunately, my medical knowledge is means the medicine part is not really very good, sir. So I need to learn a lot from this. Yeah.
No, it would be good with me. Don't worry. You teach me GYNEC, I will teach you medicine. Don't worry.
No, sir, your gynec knowledge will be definitely more than me.
No, I'm fine. Yes, Dr. Alam, what's your experience?
Sir, as usual, sir, it was brilliant because the explanation are to the point, sir. Not so lengthy, not confusing. So explanation is best. And moreover, I told you in last class also, I liked your triad that you always make.
Wonderful, brilliant. This is what I learned in my practice in last 20 years. So whenever I use this triad 100 times in a day, whenever new patient comes tomorrow morning to my OPD, I'll ask three questions to myself. What is the diagnosis? How I supposed to investigate? What is the treatment of this gentleman? That's it.
Yes,
So that makes my day. You
yes,
understand?
sir.
Wonderful. Yes, Khadija, Dr. Najir. Any comment, Dr. Najir? I think I've seen you first time. I don't know. I'm not much have interaction with you so far. Najir, are you there? I don't know. Fair enough. Yes, Garvita, how was your experience? And then we'll pack up because rest of the doctors already joined many times, so they know.
The class was really nice. Like I came to like this is the first class I've joined fully from now. So I
Wonderful.
really liked it, the way you teach and the way you tell us or help us to frame the MCQs and solve all those. It's really very informative.
Wonderful. Brilliant. So we have hundreds of video. Try to see at least one video
Sure,
before
sir.
going to
All
bed.
right, for sure.
Yeah. Well, thank you very much. Anyone else? Last, any candidate? Deepika, Khadija, any last comment?
I've attended a few classes before, sir, but as always, you've maintained the same standard and it's always been great. And the one important thing I've noticed is that when you explain questions, sir, you explain it in a way that it stays in our memory. So even if we don't end up reading it later on and you come across the question, you know the answer because of how you've made the connections in the diagnosis and investigation and treatment. So I found that really helpful. So
Wonderful. Brilliant. That's it. Thank you very much all for joining.
Thank you, sir.
You can catch off this. Feel free to call me. This is my number below there. Don't hesitate to call me. Don't hesitate to call me. Message me for any XYZ help. This is my direct number and WhatsApp. Right. So keep in touch with me. We would have a brilliant classes down the line. So we'll do it. Thank you very much and good night.
Thank you, sir. Bye, sir.
Thank you.
Yes, sir.
Thank you. Thank you. Take care. Thank you very much. Good night.